Hey, health warriors and fall prevention champions. Has a patient ever told you, the room is spinning or I just feel off? Those aren't vague complaints, they're clinical clues. Today we're untangling vertigo and dizziness, two symptoms with very different roots and serious nursing implications. Dizziness is a general feeling of being unsteady, woozy, or lightheaded, like you might faint. Vertigo, on the other hand, is a false sense of movement, often described as the room spinning around you. Both can increase fall risk, trigger nausea, and signal underlying issues that range from benign to life-threatening. So, let's talk about some common causes you really need to know. For inner ear disorders or peripheral causes, we have things like benign paroxysmal positional vertigo, BPPV, which is sudden vertigo triggered by head movement, Meniere's disease, which brings vertigo along with tinnitus and hearing loss, and vestibular neuritis or labyrinthitis, which is viral inflammation of the vestibular nerve. For central nervous system disorders, you might see stroke or transient ischemic attack, multiple sclerosis or migraines, and there are other contributors too, like hypotension, hypoglycemia, anxiety, and medications such as antihypertensives or sedatives. Now, when it comes to assessment and diagnosis, there are some key components of nursing assessment you've got to cover. Ask about the duration, frequency, and triggers of episodes. Check for associated symptoms like nausea, tinnitus, hearing loss, or visual changes. Don't forget vital signs, especially to rule out orthostatic hypotension. Assess gait, balance, and fall history, and make sure to include a neurological exam, looking for things like nystagmus and doing a Romberg test. So, let's talk about diagnostic tests that might be used to get to the root cause. These may include the Dix-Hallpike maneuver, which is used for something called BPPV. An audiogram can help evaluate hearing, and if central causes are suspected, an MRI or a CT scan might be ordered. Also, tests like blood glucose, a complete blood count, and even an EKG can provide important clues. Alright, so let's talk about nursing interventions. Our main goals are to stabilize, educate, and empower. First up, patient safety always comes first. Make sure to implement fall precautions. Keep the bed in a low position, ensure the call light is within reach, and assist with ambulation as needed. Also, dim the lights and reduce stimulation during those acute episodes. Now, when it comes to medication management, administer antiemetics like ondansetron for nausea, and vestibular suppressants such as meclizine or diazepam as ordered. And of course, don't forget to educate your patient about the timing and possible side effects of these medications. For repositioning and rehabilitation, if your patient has BPPV, teach or assist them with the Epley maneuver. If episodes are recurrent, refer them to vestibular therapy. Encourage slow position changes and remind them to stay hydrated. When it comes to patient education, advise them to avoid driving or operating machinery during episodes. Help them identify and avoid triggers like caffeine, alcohol, or sudden movements, and offer coping strategies, things like deep breathing, grounding exercises, or even connecting with support groups. Here's the bottom line. Anchor the room, anchor the patient. Vertigo and dizziness might be invisible, but their impact is definitely very real. With strong assessment skills and steady support, nurses can keep patients upright, both physically and emotionally. So, what's your go-to strategy for managing dizzy patients? Drop it in the comments. And don't forget to like, subscribe, and follow for more balance-focused nursing tips, because every step really does count. And remember, assess, stabilize, reassure.